Welcome back to Inhale Life, conversations from the Chicago Asthma Consortium, where we discuss the latest ideas, innovations, and real-world strategies to improve asthma care and respiratory health. I'm your host, Sharmili Nienhuis, professor of pediatrics and medicine at the University of Chicago. And today we're talking about one of the biggest shifts in asthma management in recent years, moving beyond rescue-only treatment approaches and towards anti-inflammatory rescue therapy, and smart therapy. For decades, many patients with asthma have relied heavily on short-acting bronchodilators or beta agonists like albuterol alone during symptoms or flare-ups. But now we know that treating only for that bronchoconstriction without addressing for airway inflammation leaves patients at ongoing risk for exacerbations and poor outcomes. And so today we're joined by Dr. Megan Elios, assistant professor at the University of Chicago, to discuss how anti-inflammatory rescue therapy and smart therapy are changing asthma care, what the evidence shows, how clinicians can implement these approaches to practice, and what this means for patients and families. So, Dr. Elios, thank you so much for joining us today.
Thanks for having me. Appreciate it.
Yeah. So to start off, can you explain what we mean when we talk about anti-inflammatory rescue therapy? And some people call that air therapy.
So yes, as you had just went over a little bit, essentially inflammation is really at the heart and really the root cause of asthma symptoms and attacks. And that's why anti-inflammatory treatments are essential for asthma control and even the prevention of long-term loss of function. So AIR, as you said, stands for anti-inflammatory reliever therapy. So AIR therapy is an asthma treatment strategy in which a combination inhaler is one that contains both medications of an inhaled corticosteroid and a fast-acting bronchodilator, such as formoterol, which is similar to albuterol but longer acting. But it's used as needed instead of, or maybe even in addition to daily maintenance or controller therapy. So essentially, what happens is a patient uses this combination inhaler whenever they have symptoms such as shortness of breath or wheezing or persistent cough, not just on a regular daily schedule. And it's really the combination of the inhaled corticosteroid that really reduces the inflammation with the bronchodilator therapy that works to like relieve the airway constriction, kind of working together just in one or the same inhaler.
Great. And does it always have to be one inhaler or sometimes, I know with some of my patients, sometimes because of insurance reasons or age, sometimes there's two inhalers, but can you talk a little bit about that?
Absolutely. Thanks for mentioning that. So you're absolutely right. It doesn't necessarily have to be in one inhaler. It can be, a lot of times with the anti-inflammatory and reliever therapy, it can be in two separate different inhalers, but you use the inhaled steroid, which is in one inhaler, anytime the reliever or the bronchodilator is used at the same time. But it's just the idea of just using both at the same time, regardless of whether it's in the same inhaler, which it can be, or in, two different inhalers.
Okay. So I know I briefly mentioned this in the intro, but why has there been this shift away from from not using albuterol only now as a reliever therapy or rescue therapy?
Yeah, that's a really excellent question. The shift away from the SABA or short-acting beta agonist only treatment in asthma is one of the most significant developments actually in recent asthma care guidelines, especially as it pertains to GINA or the Global Initiative for Asthma guidelines. And this is why the change occurred. So one, asthma, as we just previously discussed, is a fundamentally inflammatory disorder. So years and years ago, historically, it was thought to be a disorder of bronchoconstriction. So that was the idea of using this SABA or albuterol as this therapy and like a reliance on that. But as we've come to know more and more about asthma, we're really finding that really the root cause of asthma is this underlying inflammation. And that's something that we have to target in our treatment. So once again, when you use a short-acting beta agonist such as albuterol, this only provides temporary relief of symptoms by just temporarily releasing or relaxing airway muscles, but it doesn't treat that underlying inflammation that's at the root cause of asthma. And it's this uncontrolled inflammation that can, when not really treated appropriately, that can worsen with time, leading to increase of symptoms and an increased risk of asthma attacks. And lots of studies have also shown that an over-reliance just on the SABA, when you're using it frequently without a controller medication or an inhaled corticosteroid of any type, whether it's in a separate inhaler or not, it's used with a higher risk of asthma attacks, hospitalizations, and even like asthma-related deaths, unfortunately. And many studies have shown that patients who use their SABA frequently, which would mean like 3 or more canisters in a year, do have worse outcomes. So, yeah.
Yeah, no, thank you for outlining that. That's a lot of great information of knowing that, what the previous, just the previous recommendations of just using albuterol really weren't getting to the core of the disease. So we weren't treating that. So I know I mentioned earlier that there's this anti-inflammatory rescue therapy, and there is that's like a broad umbrella, but underneath that umbrella is this smart therapy. So for people and listeners that might not be familiar with smart therapy, can you tell us what it is? And again, how does that differ from the traditional like controller reliever approach?
Definitely. So SMART stands for single maintenance and reliever therapy. So it's this idea that you use one inhaler to do both jobs of both maintenance or as controller therapy, which is like daily therapy, just to keep everybody's lungs, hopefully, or the inflammation in the airways down, but also and AR in the SMART and reliever therapy. The reliever is this long-acting beta agonist, also known as a LABA. So really, it's this idea of using one inhaler to do two different jobs. And so traditionally, and a lot of times you would have, as we were kind of talking about, where you can have this anti-inflammatory therapy when you use both the inhaled steroid or the inhaled corticosteroid, sometimes with like fluticasone, also formerly known as Flovent, with a short-acting beta agonist such as albuterol. You use the inhaled corticosteroid daily as your daily maintenance, and then you use the albuterol or the SABA as, a reliever. But now it's this idea of taking kind of both and putting them into one inhaler, just with the difference being that instead of a SABA in this inhaler, in this approach, it's a long-acting beta agonist. And so it really can simplify the regimen. And there's been a lot of studies showing that it does have positive effects in, controlling like symptoms and preventing like severe attacks.
Okay. Now, I know you talked a lot about a lot of research studies, but now moving to the real world, and I know that you have implemented this air and smart therapy into your practice. What have been some of the biggest barriers that you've run into in implementing, smart therapy?
So I think kind of two big ones. There's lots of, unfortunately, but two big ones kind of come to mind. One's awareness and education. So when it comes to like clinician knowledge,
Mhm.
unfortunately, many healthcare professionals maybe are unaware of these like new guidelines, especially those global initiative for asthma guidelines that state you should no longer use albuterol monotherapy without a concurrent inhaled corticosteroid at the same time. So a lot of people, unfortunately, clinicians may or may not be aware of that, or if they're aware of it, maybe they lack confidence in like using smart like appropriately for their patients. And also maybe there's a lack of like patient understanding because patients might be confused, about using the same inhaler both daily and as needed, which is kind of more much different approach than the traditional kind of two inhaler approach that we were talking about, which was kind of more, widely use before this guideline change. And then another really big one, unfortunately, too, is cost issues. So inhaler price, combination inhalers are more expensive than the SABA or single agent inhaled corticosteroid inhalers. And also there are still lots of insurance barriers. So some insurance plans, unfortunately, may not reimburse for combination inhalers, or they only reimburse for these combination inhalers when they're used as maintenance and not necessarily as like reliever therapies.
Okay. Yeah, I know that has been a challenge. I think another one, and I think you briefly touched about this, is like in schools. I think it's challenging when for kids to have that, especially that controller therapy at home, but also have one for school. And then, as you said,
Mhm.
like I think there's just a lack of knowledge um, for yeah in schools on like, oh well, that's his controller, he or she or needs to be using the albuterol inhaler, instead. So I think that makes it confuses not only the family, but the child and the school nurse and everything.
Absolutely. So no, I actually teach a program that talks about these updated guidelines that helps to educate both clinicians and school nurses. And actually, a lot of school nurses have said either like colleagues and things like that have experienced that where they're like, well, wait a second, why isn't the albuterol in here? As this must be wrong, or something to that
Yeah.
nature. So no, that's definitely a barrier for sure.
Yeah. So that's a great segue into thinking about like what are some of the common mistakes or misconceptions that clinicians really should be aware of when they're prescribing these approaches, whether it be air or smart.
Yeah, so a big one that even me as a clinician I had to learn is that not all combination inhalers with the ICS and LABA or long-acting bronchodilator formulations are appropriate for SMART. So, for example, the only approved or okay combinations for SMART contain the long-acting bronchodilator formoterol. The reason being is that it is long acting, but it also has a quick onset of action. So, like albuterol, it can quickly relieve symptoms, so it can be used as a reliever. There are some ICS LABA formulations that do not contain the long acting or the LABA formoterol. There's one that's called
Mm.
salmeterol that's in traditional like fluticasone salmeterol and like Advair and Advair discus. That one, unfortunately, cannot be used for SMART because even though it does contain salmeterol, which is a long-acting bronchodilator, it actually doesn't have a quick onset of action. So it's not appropriate to use for quick relief of symptoms. So it can be used for this like anti-inflammatory effect, but unfortunately, it can't be used as a reliever like in the moment. And then
Okay.
another big one is maybe not in checking insurance coverage prior to prescribing SMART, or not maybe giving instructions on maybe what for parents or caregivers to do if an inhaler isn't actually like covered by their insurance. That's why I always make sure that I tell families, or I personally always try to check that information prior to writing the prescription if I can. I always tell patients too that one of the caveats is that it may or may not be covered. I might not have the most up-to-date information. And if they go to the physical pharmacy and they find that it's hugely expensive or it's not covered by their insurance, to please contact us as soon as possible and like provide our direct like contact information that hopefully we can find another acceptable alternative.
Yeah. Okay. And then also we kind of touched a little bit about this, but with the challenges in for school and caregivers regarding SMART, like how do you approach like education of those support systems about SMART? Like, are there some really good tools you recommend, or you've created your own, or yeah.
For sure. So a big one, of course, is creating always, using a personalized, updated asthma action plan,
Mhm.
especially one if you can, like tailor to SMART and providing copies of that to parents, school nurses, teachers, other after school program leaders, those sorts of things. Being able to teach like the child, the caregiver, and maybe key school personnel, like how to use maybe the inhaler and the spacer properly, keeping lines of communication open, writing emergency contacts on the asthma action plan, encouraging regular check-ins among caregivers, teachers, nurses, clinicians. And then there's also a wide variety of really great like resources out there. The SSPAC, or the Southside Pediatric Asthma Center, has lots of different like handouts and educational videos and all sorts of things. And another one too, another program is our community health worker program, and they are just such wonderful individuals who really work with the families to kind of go over all of these things and making sure that yeah, that everyone kind of understands smart therapy, the why and the how and all of that. So
Yeah.
um,
Yeah, no, that's really great. You mentioned some really good resources. I know, I think it sounds like too, one of the things it sounds like you're doing is really talking to the patients, not just once about it, but multiple times. So because this is such a new way to treat asthma, that definitely asking patients about like questions they have, or I think one of the things I hear like, oh well, somebody told me I'm not supposed to use this, I'm supposed to use just the albuterol, and just provide continuing to provide education and answer questions and being a really good resource. So
absolutely, because it can be confusing. So, always, yeah, keeping those lines of communication open, I think is really essential.
yeah. Okay. So if there's one key takeaway that you'd want patients, families, or clinicians to really remember from today's discussion, what would it be?
I think the biggest thing is just to remember that asthma is a disease of inflammation. And so you really, to treat the underlying or the root cause of asthma, you really need that inhaled corticosteroid, because if you're not getting it through the inhaled corticosteroid when you have an asthma exacerbation, you're going to need like oral steroids, which that has, it's so much more detrimental to keep receiving like oral steroids. So really just understanding, that inflammation is at the heart of asthma, and you really need to treat that. And albuterol, though it, causes bronchodilation, which is good in the moment, it doesn't treat the underlying cause, of asthma. So, there's key takeaways both for clinicians and for patients and families. So I think for clinicians, it's, prioritizing education, clear asthma, like action plans, and regularly reviewing, the patient's symptoms and understanding to make sure that, air and smart are used safely and appropriately. And then for patients and families, like, always, providing, a direct line of communication, and then always making sure that, they're using their asthma therapies as directed, and never, always, asking questions and making sure that if they have any questions, they can ask and, seek help if they're unsure about something.
Right. I think you bring up a really important point that we didn't touch upon earlier with your key takeaway about that this is a disease of inflammation. I think one of the things that maybe people or, caregivers or patients themselves, they may be nervous to use so much inhaled corticosteroid, thinking that they're using too much. But I know, one of the, I think, important points is that when they looked at the studies at people that used this, what we call anti-inflammatory reliever therapy or rescue therapy, compared to those that didn't, the people that were using this air therapy actually ended up getting overall less steroids than the people that weren't using the air therapy. So I don't know too, in your experience, if you've had any pushback from patients or caregivers saying like, oh, I don't want to give my kid my child, or I don't want to take more steroids because of the concerns of that, but actually letting them know that this is actually going to probably, as you said, lead, you know, uh, be make it more less likely for you to be using oral steroids, which has is delivered systemically throughout the body and has greater side effects. So.
Absolutely. And I always kind of address that elephant in the room, and I always kind of preface by saying, when we're talking about inhaled steroids, I know steroids themselves can be a very scary word. But if we think about it, as children age, essentially what happens is that their lungs should be growing with them up until they get to be about 20 years old. And then everybody naturally, once they get to be 20 years old, their natural lung function just decreases. And really, we want to protect that trajectory both of the lung growth and then hopefully just the normal decline to not be this really straight line of decline. And so I always tell patients that, steroids, when used correctly, or inhaled steroids, when used correctly, are, on the order of even like 1,000 times, less quote unquote strong than like the inhaled version. And, it just goes right to the source, right to, the airways where you need them, instead of having, potentially needing like oral steroids, which then of course get absorbed systemically around the body and can cause like other effects. And so I just say that, this hopefully keeps the inflammation really at a low or really undetectable level, so that we're not having symptoms, and that, our, lung function over time, doesn't, deteriorate and things like that. So I think a lot of times kind of just addressing that straight on and saying why you're doing that and how it can be helpful, as opposed to having go to the alternative route of oral steroids, I think can be helpful, at least in my experience. Then I feel like the pushback is a little bit less. Um, yeah.
Okay, well, great. Well, thank you again to Dr. Megan Elios for joining us today and sharing her expertise on anti-inflammatory rescue therapy and smart therapy. Today's conversation really highlighted how asthma management has continued to evolve toward approaches that not only relieve symptoms but also target that underlying inflammation driving disease activity and exacerbations. And really kind of, again, discussing the importance of education, implementation, so that all patients can benefit from these advances in care. So, thank you again for listening to Inhale Life Conversations from the Chicago Asthma Consortium. We will be taking a little bit of a break for the summer, so we won't be dropping a podcast for July and August, but look forward to starting our podcast series back up in September. So thank you again.
Thanks, everybody. Bye.